Hope you can see that.
Is the video visible?
Yes.
Hello everyone. All to this on alignment and balancing with robotic TQ. I am Weber Bagaria. I work at the H&M Reliance Foundation. Robotics has touched each and every aspect of our lives. While we have been used to doing conventional surgery, which was very good, there is always scope of improvement. And robotics today offer an opportunity to improvise on our result. We have all learned from the stories of giants like Nokia and have been surpassed in today's world because they did not keep abreast with the technological developments. As orthopedic surgeons, as arthroplasty surgeons, it is important that we keep ourselves abreast with the latest technology and keep on improvising our surgical skills with the use of technology. People believe that robots are autonomous body. It's just a blind plug and play, but it's much beyond that. Robotic technology is for smart people who can use it more objectively and more skillfully to enhance their skill. It's for a good robotic surgeon, you need to be more than average. And it does have a learning curve, but if one decides to apply his mind and effort to it, the results are exemplary. The key steps in robotic include three things: registration and orienting the robot, planning, basically alignment, balancing, and performing cuts or bone preparation, and the actual execution of cuts by the robotic arm. In the first video, we will see how the robot is registered. We saw the X-ray, which is standard Varas knee. The robotic drill of the robotic arm is calibrated against the robotic console. And then the exposure begins. Once the exposure is done, we remove all the osteophytes. The only difference is that if you are intending to put the femoral pins through the same incision, the incision has to be 2 centimeters longer. It's important not to remove periosteum because that makes it vulnerable to fractures. You'll see that after the tibial and femoral arrays are placed, we put them through a range of movement to ensure that the visibility is there during all the movement. This is followed by checkpoint definition, and then the actual registration begins. We start with medial malleolus and lateral malleolus to define the ankle point. We then define the tibial center. This is followed by defining the distal femoral center, and finally the hip center, which is done in a very standard navigating way. So all these things, the center of the ankle, the center of the knee, and the center of the hip joint, gives us the mechanical access and orients the robot. This is followed by the range of movement, and then the painting of femur starts. So with the use of these probes, a 3D model is created of the femur. It's pretty standard for those who do navigation, but it's important, as in navigation as well, that you capture the anterior flange and the anterior surface of the femur, and also the posterior condyles. So those are the ones that will give you a referencing for your rotation. Of course, you get an opportunity to check it with white side line, but it is good to have some points collected. The more points you collect, the better will be your model and the more accurate representation. Here you see that we are doing the white side line. Now we follow this with, of course, the mapping of robotic, mapping of the tibia side, and again pretty standard thing. The only thing is that the robot expects us to also cover the anterior surface beneath the patellar tendon and also the posterolateral surface. Same thing, if you use more point, if you acquire more point, more accuracy is there, and one should aim to collect as many points as possible. Once we have our, this is complete acquisition of all the points, we reach this screen called as implant planning, and personally I called it as a warm-up screen. This is the screen where you do gross adjustments in the size of the implant. You can shift the implant medially or laterally. So this is the 3D screen, but I like to work in 2D. So you can see that how the implant is there. Is there an overhang? Do you want to shift the implant medially, laterally, rotate the implant more? So this is a gross adjustment you do. You start warming up to the computer at this stage. Then comes assessment of the pitch, and I think that's a very crucial step. So you put the knee through the range of movement, neutral, and then varus valgus. So you'll see that this is this particular patient for whom this demo surgery we are performing. We've put it through the range of movement. This particular case is very weird because you'll see there's a lot of lateral laxity, especially in flexion from starting from mid flexion. Not very representative of a typical varus, and that's the reason I'll have put another slide which will show how it looks in a normal varus. You'll see that the normal varus will have medial side tight. So the orange that you see is the tightness on the medial side, and the violet that you see is the tightness on the lateral aspect. So both medial and lateral sides are tight when you are not taking any stress view in a typical varus knee. If you give a valgus stress, you'll see that there is some opening on lateral side. Paradoxically, when you're giving valgus stress. And of course, when you give varus, the lateral side completely opens up. This pattern is the most common pattern that we see in all varus knees. Once this is done, then we need to set the goal. This is after the acquisition of these points of the stress range of movement, we reach the heart of planning. And you set a goal. This is where the surgeon and the artificial intelligence work hand in hand and shoulder to shoulder to ensure that whatever you had thought of is delivered. And for me, I have moved on from different philosophies. We've seen, and I've worked with surgeons from all across the globe, so I know that there are different philosophies that different surgeons follow, from mechanical soft tissue release to adjusted bone cuts and kinematic alignment. And we have read that from 1970s, every decade brought about a shift in thinking. From 1970s, when the mechanical alignment was considered the holy grail, we moved on to the anatomical alignment, kinematic alignment, restricted kinematic, adjusted mechanical alignment. And I think this decade, because of robotics, I can safely term as the intelligent alignment. And I call it as an intelligent alignment because it involves intelligence of two things. One, the surgeon's brain. Second is the robotic brain. And when this is combined with the expertise and the experience of surgeon, what we get is a change. And this change is for good, and we reach intelligent alignment. And what exactly is the intelligent alignment? Is that, as in life, you know, there are certain things that are non-negotiable in your life. Similarly, when you're doing a knee surgery, you set up certain parameters which are non-negotiable. For me, it's an alignment philosophy. I would not want the overall alignment of my limb to be more than 5 degrees of varus or 2 degrees of valgus. I would not negotiate on a good balanced knee, which is 2 millimeters on each side on medial and lateral. I would want my gaps to be absolutely rectangular, or if at all, slightly loose in extension when I'm doing a knee, total knee, and slightly loose in flexion when I'm doing a partial knee. I would want my component to be positioned in a manner that there is no notching. And finally, the joint line has to be preserved. However, I can negotiate on certain things with the computer, and the computer allows that because I can see what I'm doing, and I do tend to adjust my femur positioning in the AP plane. I do play with rotations, and I can give it up to 5 degrees. As I said before, I would not accept more than 5 degrees of varus and 2 degrees of valgus. So on each side of the implant, I can accept 3 degrees of varus. Preferably never more than 3 degrees on tibial side. Most often it is less than 2 degrees, and overall 2 degree valgus, and tibial slope of 5 degrees. Implant also you cannot oversize or downsize to a great extent, and I think are negotiable are only for 1 degree up and 1 degree down. So these are negotiable and non-negotiable. So once you are clear in your mind about what you can negotiate and what you can't negotiate, it's easy to plan this screen. This is the typical planning screen that you get, and this is how we plan. So the first window is the distal femur window. You can change the depth of resection, you can change the varus valgus, and you can change the flexion extension of the component. The second screen is a rotation screen, where you can rotate, increase the rotation or decrease the rotation. Now all of this have effect on the both flexion and extension gap and medial and lateral gap. So you can play along with it. It's not necessary that everything will be cleared or completely balanced here at this stage. What it means that if you've left certain degree of tightness now in this case, like flexion and extension both are tight, it would mean that I would need to do some limited release to release both my flexion and extension in the varus. So that's the point. So So it's not necessary that everything will be managed by cuts itself. I follow philosophy of doing the cuts which are in the realm of my comfort zone and then go on to balancing after I've done the first balancing. So you'll see I've done whatever releases I had to do in the very first exposure stage. I have modified my cut and I'll go back to some releases. So it's a three thing. Now, once you have done that, once you have fixed your mind on how your bone preparation will be, then you move ahead with the execution phase. And again, it's pretty standard. I use not, I do not use all word technique. I use distal femoral and tibial thing, and I use jig for performing my AP and chamfer cut. So after you have verified the checkpoints, you go on to remove the bone on the femoral side. All the violet area that you see have resection more than 2 millimeters. The green is around 2 millimeters and white is what you want. So I'm happy to accept a few I'm happy to accept a few reds, which mean that I've gone more than what I intended to. But by and large, it should be completely white. I would not want any greens to remain. So, so the ideal would be complete white, if at all, with a few reds in between. So these are very high speed bursts. The key here is to keep moving. Don't position it at one place, because if you do, not only the arm will get hot, you will also find that sometime when the sclerotic bone is there, this will block. So keep moving this and keep irrigating it. You can use the irrigation tube provided by the company, but I'm just don't want too many tubes and things hanging around, so I don't use that. But that's a personal choice. Now you'll see that I'm marking the lug holes that will define my rotation for 4-in-1 jig. So it's like more like playing a video game here at this stage. You'll see that there's a point that you're marking out. Yeah, so you see all the greens are getting over. I'm marking the lug hole on the other femoral condyle. Remaining greens are removed, so that it becomes completely clean. Once that's clean, we verify the cut. It's within less than 1 millimeter and less than 1 degree on each side in flexion, extension, and varus valgus, which is very good. We just make some more indentation mark for our 4-in-1 jig. Then we put the 4-in-1 jig there, check once again our alignment with the verifying rod, check for the notch, take the AP and chamfer cut. This I do with the saw after I have pinned the block. That's pretty standard. There's no robot involved at this stage, but although you can do it yourself with an all-bar technique, then you don't need to put this jig out there. Then you proceed with tibial thing. I usually tend to start from the medial side, because the bone, especially in varus knee, because the amount of bone that needs to be removed is less, and I can work my way. It's an interesting technique. There are many different techniques of removing the tibial thing, and I've tried every one of them, but I find this is the easiest one. So I mean, in fact, this is what I do. It's a vertical burring, except at the point of the posterolateral corner where I use tunneling, because I'm scared of damaging the structures there, and also the patellar tendon anterolaterally. And I use a combination of not only this burr, but also my two good old nibblers and osteotome to remove those last bit of bone. So you'll see that there's only a small rim of bone that will remain eventually in the posterolateral corner. And I'll probably use a combination of manual and robotic technique here to remove that bone. Once all the bone is removed and the surface is clear white, you recheck it with a paddle. I call it paddle because it kind of looks like a paddle. And once you're verified, you put this thing and see again within the range that I wanted. So happy with that. Once you have done that and your cuts are complete, you proceed with some amount of release that you had planned. In this case, you'll remember that I had the flexion extension in both. The medial side was tight, so I did some release on the posteromedial corner. And then I proceeded with my trial implantation. So it's a CR system. I have not removed the PCL. So inserted the poly, felt it manually as well as robotically throughout the system. So I still have a habit of kind of getting a feel of the knee, how the balance looks like in both flexion extension, put it through the full range of movement, and then let computer also double check if you're getting the full range, the degree of varus valgus, and finally the stability of the implant. So you see the good range. 5-degree terminal flexion is restricted, which if you use a tunicate is there. So you see beautiful balancing here, less than 2 millimeter on ideal side. So that's it. That's how you kind of do, and then you proceed with your final cementation of the implant. So to conclude, I would like to stress on a few points. The most important thing when you're doing use any technology or especially robotics is that you must know where you want to go. Unless you are clear about your negotiables and non-negotiables, you'll keep on bluffing your own self and keep shifting the goalpost, which is the worst thing that you can do with any technology. And as I said, you should master the technology and do not become its slave, because it will only, it's got a broad database through which it tells you what to do. It's you as a surgeon who has to decide the philosophy and what's best for the patient. The aim of using technology is to make us faster, more accurate, and more minimalistic. And as I say, this is the decade of robotics, and we can see more and more things coming in this decade. So if you ask me what is the happiness, the 4 things that I look at: how well I perform my alignment, how well did I do balancing, how are my components, and how much to release. So I'm happiest when I have got an alignment within 2 degrees of mechanical axis. Balance less than 2 millimeter. There's no notching. The patellar tracking is and tibial slope are all good, and I had to perform minimal release. But it may not always be the case. So I'll be still happy if I get between 2 to 5 degree of varus, 0 to 2 degree of valgus, a slight mismatch in medial-lateral flexion extension, component positioning which are acceptable, and we had to perform moderate release. But I'll not want to be in a situation where I have got bad alignment, bad balancing, bad component positioning, and I had to even release a large. Fortunately, this last bit has reduced significantly when you have used robotic, because it preempts a lot of things when you are doing that. And this is the pie chart. So like safe zone of living for hip, I think this is something that is very close to it. The side point where your balance is accurate and your alignment is accurate. And if you're on varus side, often you're medially tight and your alignment is in varus when you do these knees. And most often I used to line up here when I use traditional thing. My experience, my intelligence would make me be somewhere here if I had all the cases. But with robotics, I think I've moved here with hitting more and more of bullseye and reducing numbers of outlets, especially in relation to the balance, but also to a certain degree in number of the alignment. So that's the skills, experience, planning, and technology for you. I thank you for your attention.